el
with
Grupo
us
de Trabajo
in this
Regional para la
webinar
Reducción de la
of the
Mortalidad Materna.
Regional
Hoy
Task
con una
Force for Reduction of Maternal Mortality.
nos va
Today we have
a
a very
el
special
periodista
surprise because
que es extremadamente
we will have with
prestigioso y
us
conocido por casi todos los que hoy
the
participaremos. Todos los días
international
lo podemos ver a
journalist,
través del canal NTN 24,
Mr.
celebrando
Gustavo
este
Alegre.
contenido de médica. Y decir que gracias a nuestra
Every
querida
day
amiga
we
Emma
have
Iriarte,
to say
panamericana
thanks
y
to our colleague and friend Emma Iriarte from the IDB
que lo invitó, y especialmente a la generosidad
that invited him, and particularly Gustavo's generosity we have with him. So thank you so much, Gustavo. The floor is yours. Thank you. All. Can you hear me well? I didn't have a chance to test the audio.
Escuchamos
Se le escucha perfectamente.
Can hear you well? Good.
No querían arrancar sin,
I didn't want to start without saying good morning and thanking you all, those connected, and those who can see this seminar later on, because it will be available online. I'm very grateful to the Regional Task Force for the reduction of maternal mortality for the invitation and this initiative, Zero Maternal Deaths, Preventing the Preventable, with a multi-sectorial perspective of equity. With Dr. Iriarte, I had the chance to discuss this issue, and I think that one of the ways of understanding it is that when we consider maternal death and visualize it, not in figures, statistics, or distant populations, but imagine it in the flesh, we realize its importance, where what is important can be available in a preventable manner. Why don't we do that? So I want to extend my gratitude to all experts and organizations working tirelessly towards the same. What we must manage today is some of the most important issues to position maternal death in the public agenda at multi-sectorial level, considering equity. The GTR has called us in this sense, and I think it's worthwhile listening to them and not me. I'm just the chairperson. To demonstrate there has been a setback in the past years in maternal mortality, and we continue with inequalities, particularly in the more vulnerable groups, Afro-descendants, migrants, indigenous people. And when we go to the causes as a journalist, as a citizen, as a son, it is there where we feel bad. The lack of prioritization of the topic, how can it be possible? And investment, low investment, this campaign of zero maternal death of GTR is something encouraging. It is increasing awareness since the 8th March. That was the International Day of Action for the Health of Women. We're starting today with the most important stage. The experts will close at initial stage to anchor it in the countries Guatemala, Brazil, the Andean region. In this discussion, we will have reviews and notes from Dr. Alejandra Corao, Regional Advisor in Sexual and Reproductive Health in the Regional Office for Latin America and the Caribbean of the United Nations Population Fund. We also have people from Pajo, Brazil, Dr. Mirna Montalmeida from the Guatemala Observatory, and Dr. Bremen Murcio, Regional Advisor of Pajo in Maternal Health, and a technical advisor in GTR. So thank you, and special gratitude to Mr. Murcio for the opportunity. And first, we'll start the discussion with 4 minutes for each of the people with us and the experts, starting with Dr. Murcio. And I will ask you to please help me with the time, not more than
para garantizar
4 or 5 minutes. I must be strict here to guarantee the dynamic of our panel. So 9 steps then to reduce maternal mortality, thoughts on the importance of data for decision-making, multi-sectoral partnerships and civil society. The floor is yours. Thank you so much, Gustavo. Precisely what is being specifically proposed by the task force.
Podríamos haber hecho muchísimos más, pero nos concentramos en 9 tratando de remedar un poco a los 9 meses.
Included more, but we focus on 4, trying to be similar to the 9 months of pregnancy. In the first step, that is central and will be approached, well, we'll approach many. One, regarding development of public policies to improve maternal health, in particular in sexual and reproductive health in general. The second one, wanting to ensure the necessary resources to meet the policies. A third, that uses the evidence and the development of policies and programs. Maybe you can show it like that. Yes, please. So the first presentation made by Dr. Ariel Karolitsky, we will approach these 3 steps because they are specifically contained there. In the next presentation, there is an overlap, you will see. In this case, step 3 once again, together with 7, identifying barriers faced by individuals closely related to the presentation to be made by our colleague from COPA, Alejandra, using data to conduct actions. And another step will be discussed from the standpoint of civil society by Mirna Montenegro. Step 4, strengthening of mechanisms for participation of civil society and accountability. And we have step 5, improving the quality of care, maternal health. Step 6, investing on health personnel. We need human resources. There's a lack, we know, of midwives in the world, nearly 1 million in the Americas, professional midwives. Step 8, improving access to contraceptive methods, because one of the most cost-effective measures to reduce maternal death is contraception with modern methods, and to care for sexual and reproductive health in some groups, as you mentioned, related to age, teenagers, adolescents in particular, to respect our times. That is it. Well, you did it in half the time. I never thought we could tell somebody, thank you for using less time than that allocated. But indeed, the idea is to have a debate. Dr. Alejandra Coroa, please help us with a regional outlook, the reasons for a reduction of maternal mortality in Latin America and the Caribbean 2015-2021. Your presentation can really help us to visualize the dimension of the problem. Thank you all. Good morning. Can you see me and hear me well? Good. Well, I won't be as nice as Bremen before me, but I promise not to go over my time. I have to give an overview of maternal mortality in Latin America and Caribbean. As you may see, we have this picture of maternal mortality right now. Here, you see how the maternal mortality rate in the region is 88 deaths for 100,000 live deaths. However, there are many countries at the right, and these are the countries where there's a larger number of maternal deaths and where inequalities linked to maternal deaths are more visible. In the next, we have the whole film in the past 20 years in the Latin American region. And you see that up to 2015, we saw a trend to reduction of maternal mortality. But in 2015, it began to rise, clearly much higher after 2020 due to the pandemic. But as you may see, according to information we have, with the countries in America and with the GTR, we've seen a clear increase, and so we speak of the setback in the past years. How is this film shown in the countries? Here, you can see what is at right, where unfortunately all countries have a curve that tends to rise. The red dots at left are higher than at left. So it means that there's an increase in this trend of maternal mortality rates. In the next, we see the countries that contribute with a higher mortality rate in the region. And here we have in the distribution of the countries that corresponds to what occurs in 90% of maternal deaths in Latin America and the Caribbean. Those countries are where they concentrate 90%. In the next slide, we see what happens in Latin America that somehow is different from maternal mortality in the rest of the world. And as you can see in the last row, you see the percentage of a reduction of maternal mortality overall. And there was a reduction, significant decrease of only 3.4% in Latin America. So you see that in Latin America, it's lagging behind the rest of the world. Now, where do they take place? In the next slide, we see that maternal deaths in our region, contrary to what happens in other regions, occurs in the health centers. Over 90% of the childbirths occur with skilled professionals, but that, except for Honduras, now that doesn't mean that they die close to the centers. Here we see who those women are, and then we see, as the presenters told us, the ones who die are the poor, rural, indigenous, and the African descent. In Paraguay, for instance, from 2015 to 2021, the mortality in women of indigenous origin is 4 times the rest of the populations. And in Brazil, we see that in addition to the African descent, there was an average of among the indigenous, for instance, in orange and yellow, are clearly higher. That is, the ones that die are the Black and the indigenous peoples, and the women with low education levels. Because here you see where are deaths in the women that are not with poor schooling. So being living in a rural area, being indigenous and having poor schooling, all of that increases your odds of dying, and maternal mortality is the most bitter phase of inequality. Well, these panelists have been really very clear. Thank you, Dr. Corral. Now you gave me the possibility to ask some questions from the debate. Dr. Gabriel Karolinsky, the contributions of the family program that is a point of reference for these activities, and the multi-sectoral approach is a relevant thing. So the contribution of monetary transfers conditioned to the Bolsa Familia program to the reduction of maternal mortality in Brazil. Could you tell us about it? His mic is off, sorry. Dr. Karolinsky, I don't know whether it's, can you hear me well now? Yes, yes. Oh, thank you, thank you. Now, first of all, I wanted to greet everyone, and I want to thank you for giving me this opportunity. I'd like to highlight 3 or 4 different things.
maternal mortality should be seen as a human rights issue, in addition to being seen as a public health problem. And there are sectors in the population that are the most affected, the most vulnerable rights are seen in among the indigenous, the poor, the women with no education. And in this context, there are certain positions that show schemes of social protection, how they can be a key intervention, how by contributing with money may help close those gaps. There are a few studies that are scientifically sound enough. Here there is a study that was conducted in Brazil by CDAX, where they would show the hypothesis that the program of Bolsa Familia, the PBF, is associated to the reduction of maternal mortality, and that increases with that increases the benefits. It's a cross-sectional study with a cohort of 100 million of Brazilians monitored time. The poorest receive three minimum wages, and the population of study was women from 10 to 49 registered in the baseline of the cohort, and they had at least one life born in their last pregnancy, and their last child was born from January 2004 to 13 December 2015. Here we see the flow chart of the inclusion, and there you see the women that are potentially included. Finally, they included over 6.6 million women that met the inclusion criteria, with 4,056 maternal deaths. The women that received the subsidy, over 81% of the sample, and the remaining 19% did not receive the subsidy until childbirth. And the important thing is that from a methodological point of view, the study has external validity because the comparison groups were adjusted to different variables. So let's see the results, the key results of the study, and the endpoint was maternal death, and we see that the maternal mortality rate in the group that received the subsidy was much lower than in and the odds ratio. It was 0.82. That is, there was a reduction of 18% of mortality rate. In the best case scenario, it can go up to 29%, and in the worst, and in the West 7%. But there are other additional benefits showing that improving the maternal, antenatal care, and increasing the interval between two pregnancies is also key, because they significantly reduce the maternal mortality. They increase the access to the control of pregnancy, and it helps avoid unplanned or undesired pregnancy. The researchers conducted a number of adjustments, and they managed to prove that the longer the exposure to a subsidy, the greater the effect upon maternal mortality. And this is verified comparing up to 4 years with over 4 years. After 8 years, the difference are statistically significant. And then the second chart, marked in red, shows the proportion of years of life that they receive the subsidy, and it increases the effect of reducing the mortality the longer they receive the subsidy. It also saw that the municipalities with very low income have the greatest impact, and the same happens with the Afro-descendants for the women living in rural areas, or those in whom the municipalities implement family programs concomitantly. So basically, these are the results, and we can conclude that in this cohort study show that a program of conditioned transfer of money can reduce maternal mortality in countries with middle income, as in Brazil. Thank you. Thank you, Dr. Karolinsky. And now we'll close the round with Dr. Mirna Montenegro. What other strategies can ensure access to reproductive and sexual health in unfavorable settings? And I ask you about the role of civil society specifically. Thank you. Thank you, Gustavo. Well, civil society sometimes is loved a lot and other times it isn't. But we have the advantage, but we are one of the components that guarantee sustainability. A matter that is adopted by civil society will remain for a long time because most organizations are quite passionate and they continue to fight. That is one of the advantages of having civil society fighting against maternal mortality. So in this we are working in a very favorable context because the components that we have to reduce maternal mortality, where there is scientific evidence, sometimes they clash against the group's anti-rights. What you mentioned initially, saying from the word mother opens affectivity among women, and that among the we need as members of the society, we needed to fight that, so to give the decision makers decisions. If I say, for instance, 4 out of 5 or 5 out of 10 women die, that gives a lot of information about. So we speak of strategic data translated into context, translated into lives. So we highlight that the right to a healthy maternity is our key. No women should die because of pregnancies. So partnerships and engaging technical sectors, social sectors is essential. And defending healthy maternity is defending families and defending lives. We also wanted to highlight malnutrition and teenage, adolescent pregnancy. Sometimes we don't see the number, how many adolescents are dying because of pregnancy. In Guatemala, girls from 10 to 14 years of age die because of rapes and violence. Now, speaking of regional partnerships, giving scientific evidence and taking some steps to reduce maternal mortality, those are key elements to keep a healthy maternity, even in such a bad context that we have at present. COVID was another thing. There were pregnancy-related and COVID-related deaths. And because in some countries they acted late to be proactive in that regard. Thank you. Thank you. I want to thank you all for those initial comments. Now I'm going to give you to ask you some questions that I think may be relevant. Dr. Corral, you mentioned that Latin America was the only region whose maternal mortality rate did not improve, and you talked about the inequalities among certain groups, and you were not the only one to mention that. Now, my question is there institutional racism? You mentioned the indigenous and the Black. Is there still institutional racism that contributes to and perpetuates the lack of a provision of resources to provide care to these populations. Thank you for your question, Gustavo. I would say that there is a systemic racism in our societies, not just at an institutional level. And racism is reflected in the poor access of those women to access to our centers. There are no biological risks because of your race. The problem is where that woman lives, the access to those centers, how long it takes her to those centers. So those women are excluded institutionally because they don't take the services next to the woman. And in a way, they do not take the strategy so that the people may access to the services. So it's much more than institutional racism. It's a systemic racism in our society that doesn't allow the woman to reach in less than 2 hours to a center, to a facility, so to go to a culturally adequate facility if she's an indigenous woman. And if she's an Afro woman, sometimes she arrives late to those facilities when they could be much more accessible.
Dr. Mucio, in that systemic racism mentioned, what about the GTR campaign? How do they approach these issues? What are the 9 steps? Well, specifically, Gustavo, first I must say that the GTR includes different organizations, the Population Fund, UNICEF, PAHO, the different banks, the World Bank, the Inter-American Bank, and many other partners. From this standpoint, may only try to work to reposition maternal mortality. One of the major issues we faced in the past years is that following the ODM agenda, the Millennium Strategic Goals, as we heard from Alejandra, maternal mortality began to decrease. But in 2015, and although there were problems, we had the Sustainable Development Goals, but we had seen a decrease of maternal mortality. So what happened was that the countries began to say, okay, we've worked well to reduce maternal mortality and improve maternal health. And indeed, this became a priority that decreased. PAHO does a 2-year program to focus technical cooperation, and technical cooperation is in line with allocation of resources. So during the first years, I would say up to 2015, most of the countries prioritized a reduction of maternal mortality. That was one of the first 3 important topics in our exchanges. But after that, it fell to the 12th or even 14th place in the priorities for countries, and that is conditioned with a lack of resources. So what do we do with our campaign in GPR, with our organizations? If we're going to continue having actions for everybody without focusing on certain groups that require more care, for example, what you mentioned regarding the existent racism that we find hard to admit, the lack of a respectful maternal treatment and even neonatal that is respectful, that isn't reaching all as it should. Because in our continent, it's quite different. You reach a maternity ward in a private hospital and you'll be offered having your companion with you all the time, that if you have any need, you will be able to channel it very fast with the health team. But if you're going to reach a hospital in the public sector, this treatment won't really be the same always. You won't even have people speaking sort of the same language, because as in the case of Guatemala, they have over 27 languages, and not everybody speaks Spanish, and much less women. Oftentimes, it's generally men. Due to the economic exchange they have with other groups, speak more Spanish than women. So these are the dimensions of the social determinants of health that we're not taking into account and are being repositioned by GTR. Well, and what about religious beliefs? I say this because in the step 8, you speak of universal access to contraceptives, but they are different Christian churches and conservative groups that may say we do not agree with that. When international agencies place their stakes on those measures and recommendations that clash with these beliefs, not only in these institutions, maybe it's beliefs that are poorly interpreted or lies that have extended, half-truths that are accepted in the rural or indigenous populations. How to deal with this to avoid they be imposed before science. Indeed, another step, step 3, evidence, and more evidence. During long years, you may recall people mention the inconvenience of the day after pill, as it was called, or the emergency contraception with the risk of producing an abortion. The evidence demonstrated that that was not true, it didn't occur, and this has led many countries during this period, based on the evidence, take steps to use these contraceptives. This recently occurred in Argentina, for example, where it is over the counter, it's sold over the counter, but in others, they require a prescription, and in others, it's very hard to access it. So I would say that in our organizations, the first thing we try to do is produce evidence and demonstrate that these actions or comments work against scientific truth. Similarly, and here civil society is a major ally, is we try to grant autonomy to women or contribute to grant autonomy to them based on this evidence to reach good decisions or the decisions they wish. Nobody forces anybody to take a contraception or to have an implant and intrauterine device. We want to promote the right of the woman to access this medication, and we have another line of work at institutional level promoting the availability of these contraceptives, not only at private level, but also at public level, where gradually we increasingly have greater success and are more open, because there are many religious movements that are being more flexible, although, as you mentioned, there are some that are extremely resistant to these practices. Racism and cultural clashes will be mentioned by Drs. Karoliński and Montenegro, please. Well, 2 matters I would like to approach. First, as my colleague just said, vis-a-vis myths and fantasies and fake news also, what is so common in this time, the answer must always be and come from scientific evidence, the most solid. And this regards what you asked before about contraceptive methods and their use. The answer is answering what sort of interventions are more effective and may contribute to a reduction of maternal mortality and severe morbidity and neonatal mortality. When you analyze the different interventions, it's clear that one of the more powerful to reduce maternal mortality is prevention of unplanned pregnancy. And to do that, nothing better than guaranteeing the right of women to access contraceptive methods. Long-acting and reversible that demonstrate a greater impact in reduction of maternal mortality. In this sense, there are plans such as immediate post-obstetric event intervention, with every woman informed and with consent before discharge from hospital, accessing long-term or long-action contraceptive methods, intrauterine device, and others. And when people are aware of this at population level, they are empowered, and women have the right to access the method. By way of example, before coming to Brazil in PAHO International Corporation, I worked 5 years in Venezuela with very vulnerable indigenous populations, and when we worked to increase awareness and with continuous education, women requested before reaching the facilities where they would have the delivery through contraception. So that is one of the issues. And this is essential to respond. Another item that is key here is, with this evidence, we must encourage the conceptual approach of the social determinants of health if we truly want to have equity and impact in equity to reduce maternal mortality for those that really require it. We must work on the one hand, improving the capacity to respond in the health services and systems. But this is a necessary condition, but not enough. We must work on the structural determinants of health, precisely structural poverty, the lack of education. And there we need public policies articulated between health, education, social development, guaranteeing the rights, closing the inequality gaps and the lack of opportunities to the population that most requires it. Dr. Montenegro, what strategies have been successful to position sexual and reproductive health issues in the agenda of the political figures, the highest authorities in the countries? Here, we need a sort of social lobby. Indeed, we might say that part of our work successfully has been on public policies, particularly when the public country signs different agreements, but also when there's a law for healthy maternity or family planning. This becomes a regulation and a technical protocol. And I think it's important to take into account the health providers, because if the protocol or regulation exists to have counseling for family planning after delivery, but if there isn't a department with it, well, they won't reach it. So this is something we must work on so that this impact be successful to have outcomes. So we must work on the competencies of the health provider, the attitude of these health providers, and likewise, women's participation. There we speak of accountability processes. If in the monitoring process we document the fact that women were not really well treated, that they were not allowed to have a companion, that they attended the health department and they did an antenatal control and measured blood pressure. That is important to improve our strategies to reduce maternal mortality. Another topic regards accountability. When we mentioned about churches, well, they have a role and function, but the health ministry, likewise, they have roles and functions. And because we live in non-religious states, the Ministry of Health must comply with the standards and protocols and goals. So in this framework, organizations must have monitoring and accountability processes. If the standard says we work to prevent pregnancies in adolescents, the ministry must count with programs to prevent pregnancies in adolescents. If we say that access to contraceptive methods is via counseling and voluntary for women, for teenagers, or men to decide, we need counseling, but also have available contraception. If I describe the 8 methods, but then say I can only provide condoms, well, I'm not allowing for the right. So all the experiences and monitoring by institutions and civil society are truly useful to modify these strategies and consider the gaps that occur to be able to close them. Thank you. Well, there's a very interesting issue in regards education, because it's at school, perhaps, at the age where women and teenagers enter this phase during which they may begin to experience their sexuality, do so with access, but also knowledge. That is the best antidote, I would say, to prevent scenarios of maternal death and non-desired pregnancies. And that we must work with the health providers and the health ministries and their teams. It's with the education ministry. That is a pathway that is also contemplated actively. Is it preventing from education? So it isn't from outside, but the individual that is growing to become an adult know how to behave, what are the risks, and what happens if I do this or that, and so on. Totally. The Ministry of Health is totally responsible in relation to comprehensive sexual education, prevention of violence, and bullying at school and elsewhere. But unfortunately, perhaps this is one of the ministries where it's harder to work. In the case of Guatemala, and why? Well, because groups that are against these sexual and reproductive rights usually work more
en el Ministerio de Relaciones Exteriores.
education and foreign affairs
Ponen, digamos, personas que gerencian
where they have people that,
aunque exista marcos legales para que haya sexualidad
or into comprehensive education, this sexual education won't go to the teachers and schools and students. What do I do? Have to do? Seek for room. And the ministry, in the case of Guatemala, it's in the syllabus. But if you see what happens, we have a break. It's easier to work with health than with the Ministry of Education.
Doctor Mucio, sobre este tema, la educación y
Dr. Mucio, what about this education and dealing with ministries? How important is that in the strategy that is being implemented? Well, the short answer is it's essential. At the ministries of health, together jointly with the ministries of education, their joint work is key to protect the rights of women. But as the previous Mirna said, it's very complex. Although from the United Nations we have promoted multisectoral work, we need to work much broadly. We may have the best teams willing to help, but if you don't have the roles, there is still sexism where the wife or the mother-in-law won't let the woman go to the facilities. Today, it will be impossible for them to come. But going back to the specific issue of education and health, I think that it's one of the most complex steps. When I was the mother and child director of the Ministry of Health in Uruguay, it was almost impossible. They participated in the initial coordination meeting, but at the time of implementation, then education would abandon the work with their with their little resources. Uruguay is not a religious country, so there's no but there are groups that are always reluctant to include certain topics in education, but sometimes it was impossible to coordinate enough. So we've seen that what works in the end is when the coordination is done from an upper echelon, when the president or a first lady sometimes adopt the theme as a priority, as a core priority, and they start assigning resources and responsibilities because that is essential too. So it is then that these processes start working more smoothly, and not when you just have a coordination between the Ministry of Health and Education. Dr. Corao, I see that you activated your camera, so I think that you have something to say. Thank you, Gustavo. Yes, indeed, especially because I was reading the chat and the wonderful comments by the speakers, by the audience. I wanted to highlight the importance of fighting against adolescent pregnancy to reduce maternal mortality, not only because the girls under 15 are at a higher risk than dying during childbirth, and the pregnancy in our region among girls under 15 is significant. Also, the risk of Every time a woman gets pregnant, proportionally, she's at higher odds of dying because of pregnancy-related causes. And so if a woman starts bearing children at a young age, so by the age of 30, she'll have more than 5 children, and women that have more than 5 children are at a higher risk of dying. That is why OSPA is approaching among the strategies for maternal mortality rates, strategies against adolescent um, um, pregnancies. It is estimated that in Latin America there are 1.6 million pregnancies among adolescents and 40,000 in girls under 15. 74 of the pregnancies are pregnant that are not intentional. That is that the girl didn't want to be a mother. And there, the issue of having access to contraception is essential, ensuring that the demand is covered, and to ensure the provision of contraception is essential. So you may teach about education based on gender equality, human rights, and based on evidence-based from very early ages. So that continues to be a significant challenge in our region and needs to be approached in a multi-sectoral approach led by the ministries, by health. Now, there is an element that cuts across the region, and that is sexism. And one of the things that I learned working in communication for these approaches with Dr. Iriarte is that when you speak of mortality rate and sexual reproductive health, we can't speak only of women. We need to talk about young men, young boys. How can you involve them, engage them, so that they will be aware of their responsibility to prevent adolescent pregnancy? This is not a problem of adolescent girls, but all adolescents, including males and females, boys and girls. So we can't forget them or take them from the equation, right? Absolutely, Gustavo. And the key is at school. That is why sexual and reproductive education is essential in primary school, middle school, and in our region, we have a very high rate of schooling among our children. So giving evidence-based education is essential, but we have to approach it also outside of school. And adolescents is crucial. At UNFPA, we have very successful experience in collaboration with young boys and girls using their methodologies, and so that we can take a shift in paradigms in culture. And if there's a time where we see that a man, in a way, is accompanying woman, is during pregnancy, there's a lot we can do to change cultural patterns at the time. But we sometimes, as healthcare providers, neglect that participation of men. There's something that I'd like to speak of, the conditioned monetary contributions, and it is identifying the resistance that you may have found in programs like this. That is, by conditioning, you can lead to discomfort at the ministries. How can you overcome that resistance by the officials that may not feel comfortable because of that conditioning in those programs that end up being successful, but that sometimes implies shaking their ground, telling them that they need to do things differently, and to imply them so that they will be part of the solution and not part of the problem. Well, what you just said has to do, I understand, when you speak of reluctancy or resistance against some of the measures that some political sectors that say that these are measures that are populistic and they don't solve the problems. But conditioned transfers seek to favor the change of the situation that woman and her families are to produce phenomenon of continuous improvement of their social and economic status. And there are very clear examples. Immediately, the receiving the conditioned transfer that subsidy gives autonomy to women as the key driver of changes at home, buying food, greater mobility, greater access to health facilities. Another important thing has to do with improvement, and it's been shown, improvement of the education of those women a long time when they receive subsidy. And what you need to look for precisely is not to perpetuate that subsidy as expensive, but just to improve their situation, the economic and social situation. That is why it's conditioned to guarantee education in the case of Brazil. Bolsa Familia, for instance, conditions those presence at school at in a certain percentage, about 75%, if they are to continue to receive the contributions in Argentina too. By if the women attend the antenatal visits, or if they have the immunization schemes updated, those are required, and that is what contradicts those arguments against these conditioned contributors. Because in the end, the rights of those women and families need to be protected from the vulnerable situations. Well, the public finances of most of the countries and the multilateral agencies, sometimes they have limited resources, and this has worsened after the pandemic. Could you, in 30 seconds, tell me about, in this context of limited resources, specifically in mid and low income countries, how can you use best the resources or strategies, proven strategies to reduce maternal mortality? Let me start with Dr. Bremen de Musio. In 30 seconds, please, so that everybody will have a chance. Thank you. I'm going to try to keep my time. I love 5 seconds. I'd like to highlight a part of your question, and it has to do with innovation, because sometimes we focus that we have to innovate to change things. In maternal health, we know what the strategies, what the successful strategies are, and what are the strategies that fail. Now, this has to do with what Nina said. There are provisions, regulations, plans, but they're not implemented the way they should, and or they're not implemented. So our monitoring and evaluation of those interventions is essential if we want to correct what did not succeed. So we could re-accommodate those scarce resources, sometimes they are not so scarce, to use them in those places that need more care. And particularly inclusive, we go back to prioritization. If the governments continue to consider that this is not a priority, they're not going to allocate any resources. And if the communities do not ask for the right and needs, they won't be allocated any resources. Dr. Corao? I lost 2 seconds. Well, as Bremen well stated, we know that it works for 30 years for a woman to get to childbirth. She needs to get pregnant. She needs if she does, she has an obstetric problem and not to receive good care. So we need to guarantee that the pregnancy happened at the time where it should. If there's an obstetric complication, she needs to be aware that she has a complication. She needs to be close to the facilities with proper transfers, and she needs to know how to reach them. And she needs to go to a healthcare center that may give obstetric and neonatal care of emergency. We know that 30% of maternal mortality would be reduced if they had access to family planning, and we know that 65% of maternal mortalities would be solved if women could receive obstetric care within 2 hours of part of the problem. Well, the budgets are decided at a high level. The second is to prioritize, because not all places need the same, so you need to prioritize. And the third is to measure, because if you don't measure, you won't know what you're using the money in. And fourth is local engagement. Men, women, the community, the department need to participate in the processes. Thank you. Thank you. Well, and finally, Dr. Karolinsky. Thank you, Gustavo. First of all, we need to consider that there's no silver bullet to reduce maternal mortality. It's a complex problem that requires multiple factors of intervention. But if answering your question, I want to state clearly that there's a primary responsibility that is political, and there is responsibility for doing things, but also for omitting to do things. If we know what are the interventions that produce the highest impact, for definition, when prioritizing and defining the budgets, you have to do with those that exert the political and economic power in each of our countries. If we can have an impact with, like in this, as in this program, to get a political will to protect these sectors, we'll be able to solve this situation that is a blow and that induces us to work hard so that fewer children and fewer women may die at childbirth. So I can't omit, and this is a question that I ask particularly Dr. Corao, in that regional landscape that you showed at the beginning, what has been the impact of the pandemic? We know that it limited mobility and access and other consequences in the access to health in general, but in this particularly.
Como elaboradores de políticas públicas, acompañadores de ministerios, expertos.
Accompanying ministries and experts in the field. What lessons have we learned with the pandemic, looking at the data to prevent this occurring again, or to have lessons learned? The floor is yours. Well, we would require a whole webinar for that, but in a nutshell, first, I think that all the participants are aware that the pandemic had a harmful effect, but that we were not in a good condition before. And I say this because sometimes we blame the pandemic for the setbacks in maternal mortality and all the progress that had occurred in the region. The pandemic clearly strengthened this issue that we were facing in the region. And why? Because we had people farther away from our services, and these were to be essential services, providing contraception, so people didn't come for antenatal controls, and couples didn't come to our services to receive a human rights care. So the people must really work in this sense so maternal death doesn't increase. But during the pandemic, we have to analyze that not all the women died during delivery. The more vulnerable women died, the less educated. I hope that we learn that there is a right to have resilient health systems, because we will surely have a new pandemic. We must be prepared so that the essential sexual and reproductive departments never again close due to other problems. Thank you. Well, we're going to close this seminar with a note of hope, because on the one hand, we realize that the problem remains, the data placed before us, the need to continue working, but listening to the experts, we realize that there are people working there in this work that is being conducted and of course may be improved. And that is why we have these webinars that contribute to raise awareness regarding the importance of prioritization of something as essential of what one of panelists said, and that is, who gives life cannot face death. So thank you, GTR Group. Thank you to all those who connected at regional level. I hand the floor again to Dr. De Murcio, with whom I discussed to prepare this webinar, and I thank him for trusting me to chair to learn from your voices. Dear Gustavo, it is we who are truly grateful, because you really chaired this webinar in a wonderful manner. People were very captured. We have a large amount of questions at the heart due to what she triggered. So it is we who are grateful to you and to all the panelists and all the GTR members who have really worked so that we could have this meeting that I think has been very good, with a dynamic that is quite different from other meetings we've had. So once again, thank you, Emma, who said, I have the right person to this meeting, and that is why we're with you. So I want to thank the over 300 people who connected live. We didn't reach the 2,000 and over we had before on YouTube, but the context was different. But to wrap up, our next steps now are focused on encouraging this campaign in the countries and regions, no longer with this sort of webinars at regional level, but working directly with the countries that need direct support from the GTR to move forward the agenda of reduction of maternal mortality, and that is why we worked here today. So thank you. I'm extremely grateful towards you, Gustavo, and see you again in another event. Thank you. All the best.
Y ahí está, crece que crece cada día más y cada vez más intenso, y todas esas emociones de ser mamá.
Baby, we're really having this sort of baby inside is extremely moving.
Mucho la misma línea de pensamiento que tengo yo, que yo quiero. Pero eres tú la que va a parir, no soy yo la que va a parir.
It is you who will have the baby. You have to decide.
Me tocó una doctora que obviamente estaba muy bien preparada, que tenía mucha experiencia, porque todo lo que ella me dijo, yo solamente la letra, ya con eso.
With experience, and I followed her indications. Well, that was it. Can you imagine what happens when the baby passes through your canal? You can't believe the capacity of your body for having a baby. It's unimaginable.
I had to be induced, and I did get an epidural, but otherwise it was a vaginal birth. Without the midwife, I don't know if I would have been able to do it. She coached me through it and made me feel relaxed, and I'm very grateful for actually having her in the room, because otherwise it would have been a bit difficult.
pero ella me indicó todo, me dijo que ella estaba en trabajo de parto y me dijo que me iba a ayudar durante el proceso. Durante todo el parto no tuve miedo porque ella me ayudaba, ella me estaba ahí constantemente conmigo, dándome fuerzas, todo salió muy bien gracias a ella.